Okay, welcome everybody to the seminar on precision medicine, a health economic perspective. So I see that there's a lot of people signing in, but just to keep on track with time, we'll start the seminar. So it's a great honor to invite you all. So this is a joint collaboration with BigMed and the University of Oslo. So from the registration list, we're really happy that so many have participated and signed up. So we hope this will be a good meeting today. So the plan is, after some welcoming words from the project leader of BigMed, Vibeke Vallevik, we will have a keynote by Apostolos Tsiachristas from the University of Oxford, with some time for questions afterwards. Then we will have some pitching of research in the next section before we have a discussion part at the end, which will be in Norwegian. And since this is a digital seminar and we're not able to meet in person, we have some rules for you or some kind of information. So as an attendee, you will not have a camera or a microphone. I could open it, but I think we will stick with this organization. So we would very much like you to take part in the discussion. And if you have questions for the presenter, please use the Q&A channel, which is on the bottom on the Zoom. When you activate the Zoom, you can add your questions there. So there will be no raise hand function. So if you have any technical questions, you can use the chat channel, and we will try to handle it as best as we can. And the English part of this seminar will be recorded. So, so then before we start, I will give the word to Vibeke Vallevik, who's been the head of the BigMed project. So please, Vibeke.
Thank you, Lina, and hello, everyone. I'm so excited that we have so many people here today and for all this very interesting topics that we're going to cover. As Lina said, my name is Vibeke Binz. I am the project manager of the BigMed project, which is hosted by Oslo University Hospital. So there is where I spend my every day. I also work at DMVGL, the Precision Medicine Research Program. Now, BigMed is a project, a lighthouse project that was rewarded funding from the Norwegian Research Council almost 4 years back now. And at the time, we were the biggest precision medicine initiative in Norway. And with a vision to pave the sort of pave the way for projects like this, and the clinical implementation of precision medicine has been our main focus. So we've been looking at the barriers for implementation of precision medicine and seeing what can we do with those. The way we've organized ourselves is through focusing on some clinical work packages, so clinical areas, and using the needs from that to develop tools and solutions. And we have around 20 partners from academia, from the clinic, from the legal side, from patient organizations, and from the industry. And we think this cross-competence way of working has been very, very useful. Just before we dive into it, the way we define precision medicine, I think, is worth spending a minute on, because for many, when we say precision medicine, they think genomics, which is a big part of it. But the way we look at it is also the fact that you go away from this group thinking in terms of diagnosis and one treatment fits all, and into looking at all the different individual characteristics of a patient that can be displayed in the whole complete data set about a patient, and seeing what kind of treatment can be targeted to this person in particular. And that gives lots of challenges in terms of cohorts, going away from group thinking and averages and into this more individual focus. And so in that sense, it all comes down to the data. So this has been a project on data sort of in the big terms. And it's about secondary use of data, and it's about using real-time data from the clinic. So we created this pill for precision medicine, which is about you need all of these components in order to actually implement precision medicine in the future, in this whole new paradigm. So you need the infrastructure to support it, you need legal and ethical frameworks, you need to capture data, have new ways of analyzing it, you need to bring it to the point of care, to the decision maker, and you need to have organizational and financial tools to help make these decisions. And this is where health economy comes into play. And we've seen throughout these 4 years how big of an impact this has on the whole way that we are delivering care, and the financial incentives and sort of as a methodology supporting the decisions that we make. So we think this is very important. This project has been about also a lot of legal issues. It's been, for instance, one of the things that we've been looking at is we made a tool for sharing of genomic variants, which is something that is needed in many of these clinical working groups that we have. But when it came to actually implementing it, we saw that there were some legal issues. So we had our legal team develop a new sort of methodology of evaluating the risks, and then being able to conclude that this is safe to use, and now it has been implemented. So this is the way we've been working in these cross-competence teams, and we see a huge value of academia also in this. And this is why we're very happy that the University of Oslo is a big partner in this project. So today, as I said, we're focusing on health economy, and I'm super excited to hear what you all have to share with us today, and really looking forward to the day. So thank you.
Thank you, Vibeke, so much for giving an introduction to everybody about BigMed, which this is a part of. So now I'm really happy to introduce our keynote speaker today. I'm so happy that Apostolos Tsiachristas said yes to give a talk to us today. So he's an associate professor at in health economics at the Health Economics Research Center at the University of Oxford. And while looking at his publication list, you can tell that he's broad experience in health economics and economic evaluation within a lot of different conditions and several study settings, from experiments to big models. So Tsiachristas has, together with one of our colleagues, joining this Horizon 2020 funding project, HEcoPerMed, which we are going to listen more to or learn more about today, where they're discussing actually health economics and precision medicine. So I'm really looking forward to your talk, Tsiachristas, and so please, the floor is yours.
Thank you, Elina. Can you hear me, and can you see the slides already projected, full slide?
Yes, I can.
Perfect. So many thanks for inviting me to give some of my insights in the financing and payments, and as well as the economic evaluation of personalized medicine. I was really pleased to see that BigMed, from what just Vibeke presented, they really appreciate the importance of the financial tools that are necessary to be in place to have the development and uptake of personalized medicine in not only Norway, but also in, I suppose, in many other countries. So I'd like to share my insights based on HEcoPerMed, as Eline just presented, and I'd like to acknowledge the partners really in these European funded projects. This is the AIT in Austria, the DLR in Germany, the IMTA at Erasmus University in Rotterdam, the Syrian team in Budapest, and the Health Economics Research Center where I'm based in Oxford. I hope before I start, you're all as hopeful today as I am. Not first of all because of the vaccine, right? Although it's not the the vaccine developed here in Oxford, but I'm sure this is good news for everyone. So hopefully next time I'm going to meet, it's going to be in person. But let's see how things develop there. So I'd like first to give you an overview of the HEcoPerMed project. What we are tasked to do is two things, really, two main things, two main components. The first is we're looking for the best health economic modeling approaches for personalized medicine. So this is a pure health technology assessment, HTA methodological bit that touches upon many current ongoing debates about how we should be going on as health economists, as modelers in evaluating personalized medicine. The second bit is what's the best way really to use this economic evidence in providing new structures of financial incentives and how we can engage payers and manufacturers and regulators in a way that they have a win-win situation. They're mutually interested in investing, adopting, and uptaking personalized medicine. So we are different streams of work based on work packages, as you can see here, and the outcomes are expected to inform the European Commission, because this is a project that is funded by the European Commission, but is mainly targeted to support the international national platforms and mainly the International Consortium for Personalized Medicine. So these stakeholders are already engaged in our projects. Now, I'd like to, in the next 45 minutes, really 43 now, I'd like to touch upon the landscape of personalized medicine from the perspective of a health economist. Obviously, I'm not a clinician, I'm not an epidemiologist. I'd like just to list really what the challenges out there are with regards to personalized medicine and its adoption. I'll also make some questions whether we need to change things, and if so, how we should be changing things. And of course, I'm going to be focusing on two things. As I said, the main things are financing and payments that should probably be re-engineered or just adapted to finance and pay personalized medicine, and of course, how we go about evaluating personalized medicine. And I will end my talk with some ideas, really, and I'll just trigger your interest for the last slide, which is probably a personal idea or vision, really, of how payments should be in personalized medicine. So I hope you're already intrigued for the content. So first of all, this is how a health economist see really personalized medicine. So we acknowledge that the treatment effects of innovations is not the same across gender, across age, across ethnicities, and in general across any different subpopulations, because there is large variation in the treatment effects. So we know that, and because we have acknowledged that, we see that there is masses of developments of personalized medicine across the whole care continuum. So from the very beginning, from screening for risk factors to diagnostic testing, prognostic testing, up to therapies and surveillance. So we do have examples of personalized medicine that have been implemented. They are many of them are already part of our national health systems, or health insurers in other countries reimburse these personalized medicine innovations already as care as usual. Now, I'd like to show you the trends here. This is reflected in these numbers. So the increasing trend of adopting personalized medicine can be seen in the first slides, which is, I'm going to use the pointer. So you can see, so in this graph here, you see that from 2014, where there were only 21% of all FDA approvals were for personalized medicine, that was doubled within 4 years, really. So it ended up to be 42% of all FDA approvals that were regarding personalized medicine. And that's a massive increase. We also see that recently it is approximately, or companion diagnostics account for 20% of all medicines currently approved by the FDA, which is again another big step in adopting companion diagnostics for these medicines. And also there is a large pipeline. You see it here in across different countries, not just in the US, in the EU, but also in China, Russia, and Korea. You see that there are at different stages of development. There are a number of gene therapies and gene editing therapies in the pipeline. So that gives us an indication that there is an increasing trend, positive trend of developing personalized medicine. Now, the good thing is that these trends in time were accompanied by a reduction in the costs of genome sequencing. And we see here in this graph that the costs of a genome has dramatically decreased in the last at least decades. And this is very promising. So technology improves and we can have genome sequencing at less costs. And of course, this has been all over the news. It has received attention, and that brings, I suppose, the hopes and expectations of personalized medicine to even higher level. And I'd like to show you here the benefits, right? All these expectations summarized in these graphs. So we have indications of personalized medicine used in prediction of disease, in early indication of disease, on diagnosis, and we, throughout this care continuum, we accumulating benefits, and you can see here some of them. And what we are after really is improvements in the outcome, as you can see in this bit here. So we want the therapies to have reduced side effects and adverse events, etc., to improve patient experience. That's also a very important aspect, as Vibeke mentioned at the very beginning. It's the whole umbrella term really of precision medicine, not just genomics. And of course, what we're after, and this is really for the target for health economists, but of course for the overall healthcare system, is we need to increase efficiency. We need to streamline care pathways. We need earlier diagnosis and treatment. And of course, we need fewer adverse events and incidents. And if we do that, of course, that wouldn't have impact only on the healthcare system. That's a very important point, especially in personalized medicine. This is not just on the benefit of NHS, National Health Systems in different countries, but it's really is going to deliver the benefit for the overall economy. We're talking about increased productivity. We're going to have a healthier healthcare workforce. We're going to have less need for informal care. And what we are also hoping is that all this innovation, not only clinical innovation, but also research innovation, will also bring more efficient and more ethical RCTs in place. Now, there are some studies that have shown already that personalized medicine or some types, some specific innovations of personalized medicine can reduce costs, as you can see in the left figure on this slide. That's a study from Plan and Vervaart, 2016. They've done some estimations of breast cancer therapies with and without gene sequencing, and they've estimated that having the gene sequencing would reduce costs spent per patient. And another study published in Lancet in 2015, they've also tried to I suppose, estimate based on, of course, extrapolations and many assumptions, but still with many of them being based on, I suppose, reasonable expectations, that they've looked whether introducing personalized medicine would save quality adjusted life years, which is a measure that health economists use to express longevity and quality of life at the same time. And they have shown in the study that indeed that would increase, quality would be increased across different chronic conditions, really. So large expectations. There is some evidence that personalized medicine could achieve these benefits. And there is also the question, okay, if it's a win really for the society, if we can have, less cost for the healthcare system and also higher population health, improved population health, is it a win for manufacturers as well? And of course, another study has discussed this, and the argument is that manufacturers of let's say, drug therapies could increase the revenue because of faster entry to the markets of personalized medicine, of the drugs, faster rate to the peak, really on the top. They stay longer at the peak, so they have more sales volume, and of course they have an extended life of the drug under question. So it seems that all these expectations and the benefits are creating really a win-win situation for everyone. Now, let's talk about the payers, right? Because we talked about the public, we talked about the manufacturers, but let's think about those that they do have the budgets and they have to pay out of this budget for personalized medicine. And this is just a simple figure here, just to say in the EU we have, hospitals can pay from their hospital budgets for personalized medicine innovations, or health insurances in some other countries. In the US, private health insurers can pay for personalized medicine or Medicare, and all these, of course, can be supplemented with out-of-pocket payments, so direct payments from the patients themselves. And what we've seen is that whoever the payer is across the world, we see that there's an increase in spending for treatments. And that's one of the assumptions, is that personalized medicine has had a positive effect on this increase on spending per patient. And I give you here just an example of the rapid increase for monthly spend per cancer patients in the US, that has increased by 55% in the last 10 years only. So all these innovations, of course, we cannot attribute only this increase to personalized medicine, but we do make the argument that personalized medicine has contributed to this increase. But if the payers then pay more in recent years for therapies or for the treatments of patients, what are the expectations really back from these innovations? This is the two tables based on another study. You see here there was a survey really across different payers, and they asked them, okay, based on these criteria, which of these criteria you think you should definitely have evidence for, or you should consider before paying for personalized medicine. And you see that for drugs, they were more inclined to look into life expectancy and clinical effectiveness. 5 is the highest score, though, strongly consider them, and 4 was the second one. But when we look into the tests, we see that the expectations of the payers for genomic tests or combined diagnostics were way much higher. So the expectations were about making the link with the underlying therapy, about clinical utility. They should have information about the health outcomes, etc., etc. Of course, the cost of test was probably one of the least strong impact or criteria that payers would like to have information upon before making a payment. And just to give you an indication, payers requested, let's say, for diagnostic reimbursements, for diagnostic tests, they were expecting that approximately 11 to 30% of the improvement in treatment response. That's a big number, isn't it, to expect this as an improvement in the treatment response. And of course, to have 3 to 7 month improvement in survival of the patient. So that was quite surprising, really, that payers have such big expectations from the tests themselves. Now, let's see who are the manufacturers and how this has changed, this group has changed in time. Traditionally, we from big pharma pharmaceutical companies are engaged in the translation, commercialization of innovations. Small businesses are more into R&D and translation. And then, of course, we have the academia and public enterprises mainly involved in the discovery and R&D phases. But what we see recently is that we see a change in the mix of these stakeholders, in the mix of manufacturers. And we see that, for example, academic institutions make moves towards developments, and CROs now are more involved in discoveries, and government is also involved, of course, with public-private partnerships in developments of personalized medicine innovations, and large health IT companies, of course, are continuously supporting the developments of personalized medicine innovations throughout the life cycle. And that's, of course, denotes the need for big data and the importance, I suppose, of this data in any phase of these innovations. Now, I hope I've set the stage right about this, but do we need to change something to have an increased uptake of personalized medicine? A quote here, nice, that says there is great uncertainty and there is also high potential for benefits. I've shown you these expectations, and they suggest that there should be some innovative payment methodologies that they should be developed to manage and share risks and to increase access of patients to these hopefully beneficial, cost-beneficial innovations. But then again, there was also the question, okay, how to determine the price of these and capture the value, therefore, and how we can include discriminatory effects and unmet needs and innovation and real-world evidence in these payments. So all these questions have to be now considered in our regulatory framework. And this is what we've done so far. We have mechanisms, we have tools that can increase timely access to these innovations. The boxes in green and purple are mechanisms that we have in the EU, the blue are in the US, but what we see is that we do have some clauses, let's say, some tools to have an earlier entry of these innovations to the market. And of course, we have then the HTA bodies that look into managed entry agreements, funds, patient access, etc., etc. But what we should be thinking is that we have these two distinct phases. We have first, before the approval, we have the funding. Problem is a mix of public and private sources, as I've shown, in different phases of the developments and R&D and phases of treatment, but also then after having an innovation approved, then we have in the reimbursement phase, we have the payments and the wider clinical implementation. Now, the arguments are that the approval and market access does not guarantee reimbursement coverage, so it can enter the market, but then obviously the manufacturers probably are not 100% certain they're going to get the costs at least covered. Another argument is that the R&D costs and the added value of personalized medicine, that's a crucial bit here, are not reflected in current reimbursements, and maybe we need to have new payment and cash flow models, as we are not really capturing in our current models, payment models, the value of personalized medicine. What that leaves us with is that manufacturers, this is an example of companion diagnostics, manufacturers do not have incentives really to engage into large RCTs because they're very costly, obviously. There is large variation in coverage and pricing or in diagnostics, and they're mainly based, the prices are based on costs, not really the value. And of course, they have separate evaluation process than the underlying therapies. And of course, there's limited access to the patients, as regulators do not really have substantial evidence for the cost effectiveness of these tests, and therefore there is also increased out-of-pocket payments. Now, let's see what we can do better in terms of financing and payments. We have done a literature review, and that's the first one in this field, I suppose. And what we've done, we looked into scientific and grey literature to see what examples are out there of financing and payments. And we ended up having 114 studies that we looked thoroughly through, and most of them were about financing models and discussion papers, so they were not really implemented, but they were really suggested in the literature to be implemented. And the majority of the included papers were about reimbursement, so payments. And you see here the distribution of these selected studies across the globe. 60% of them were from the US, and then the rest followed by the EU and Asia and Australia. What we see here, what we found is that financing of R&D for personal medicine, it was mainly based on public sources, so governments, EU, European Commission, medical research councils, academia, private as well, and that included the industry itself, but also venture capitalists, philanthropy, I will come back to that, and health insurance. And also there's a nice innovative financing model of HealthCoin, which is based on blockchain in the US. But we've seen that there is also increasing overlap between public and private sources, and we have found some interesting examples of public-private partnerships. This is just a graph to show you the increase of venture capitalists in biotechnology, but this is also followed in other areas of personalized medicine, and we see that there's increasing investments in these technologies, even above, as you see here, even above all the deals that there were between venture capitalists in time. And this is very hopeful that there is interest, since the markets really and venture capitalists invest in these technologies, there is interest that the expectations for these are going to be met. This is about venture philanthropy and social investments. This is the European Venture Philanthropy Association. So philanthropists invest their money, they don't expect any return, but they do finance R&D of personal medicine. And in some other cases, we have seen also the social impact bonds, the SIBs, which are like financial bonds, but here the return on investment is way much lower. And the success of the bonds is based on really the benefit that the society is getting out of these bonds. So nice examples, but obviously not enough to finance massive development of personal medicine. And therefore we've seen that public-private partnerships are the more sustainable form of financing personal medicine. And of course, we've seen nice examples and even nicer examples between these partnerships. And I just list some of the, I suppose, examples we have in the EU for such partnerships. Now, I'd like to go to the reimbursement models or payment models. This is based again on the results we got from the literature review. You see here the y-axis about risk sharing, the lowest is non-risk sharing, and this is about outcome or non-outcome based payments. Traditionally, what we have at the moment, or most of the majority of the payments at the moment for personal medicine are in this quadrant here. We're talking about higher weighted DRGs or some upfront payments, obviously, but also bundled payments, etc., etc. We see that there is an increase, a trend, let's say, to move to risk-sharing agreements and payment models. But obviously, we haven't been to the point that we are having risk-sharing and outcome-based agreements. We are still, most of the agreements we have so far are really volume-based and cost-based. And as you can see here, these are the managed entry agreements with cost and volume. What we are after, and I suppose this is where we are going, this is probably the final destination, is this bit here, the value-based agreements with risk-sharing and outcome-based contracts. I will come back to that in a bit. So what's really the risk-sharing is the manufacturers really have confidence, of course, large uncertainty, but they have confidence in a certain innovation, and they want to get in the contracts with the payers to get the rewards or a penalty in the future. And of course, there is uncertainty, and they get into the pricing, they get to agree the price level and the revenue received, and then most of the times they try to use real-world evidence to assess the performance of the innovation once it has been in the market or it has been given to patients. And such agreements have, of course, risk and benefits for both manufacturers and payers. I'd like just to highlight two for each party. For payers, you see that is the evidence generation to reduce uncertainty, a major thing, and of course to control budget impact and budget predictability. And on the other side, for manufacturers, is indeed important to have the reimbursement earlier of the innovation, but also to have improved cost effectiveness with the net price of the innovation. This is an example of risk pooling model. This is from the US, the orphan reinsurer and benefit manager interactions. So what this is really is, here is the third party. What it does, it pools risks. First, it determines the patient eligibility for the risk pool. Then it contracts with different health insurers in the US, and they pool all the risks for these patients that have they're holding specific health insurance with them. What they do then, they get into contracts with providers that they develop efficient clinical pathways and of course guidance based, and at the end they go to the developers of these innovations and they get into value-based agreements in order to provide the necessary innovations, personal innovations for these cancer patients. So this is rather a complex model, but it has been done in the US. I'll just about the performance-based contracts. So this is based on the future payment. This is a milestone-based contract. Very simple. Is we get into the contract, payers and manufacturers. Patients get the treatment. There is a total. The total payment is upfront, and then after, let's say, a year, we look into an outcome metric and see if that's reached. Then it's fine. If not, then there is a rebate of the manufacturer to the payer. Another annuity really based contract is when we have similar structure, but then in the beginning the upfront is just a partial payment, so not just the full payment as it was before. Patients can also get into co-payments, supports their own treatments, and then what happens is the remainder of the payment is being paid from the payer to the manufacturer in installments after having assessed specific outcomes. So if they've been met, then the payment is being done. and this has happened. This is not just science fiction, I suppose. This is in the Netherlands, such a performance-based contract that was for cancer patients again. The time that for those patients that they progressed to in the cancer stage, then there was no reimbursement for these patients, and of course the costs were borne by the manufacturer itself. Now, very quickly, I would like to touch upon the managed entry agreements, and these have, they have increasingly are the contracts really that's risk-sharing contracts that we are observing in the EU and the US. They aim to manage budget impacts and, of course, to reduce uncertainty and cost effectiveness. And the financial based managed entry agreements, they aim to decrease the price and to limit the utilization, so the volume, and that's how they want to achieve more favorable ICEs, incremental cost effectiveness ratios. While the performance-based managed entry agreements, they aim to have their investment for a limited time period, have it in the market, collect additional evidence, and then have again an update of the decision based on really the outcome of this innovation rather than volume and cost. But how far? So far, we've only observed financial managed entry agreements in the EU and the US. Right. So about the financing, not the payment, so the financing, how we finance the R&D of personal medicine. The facilitators that we got from the literature are, it has to be a win-win model, and it has to really engage both parties into a conditional approval. So again, we need to have an early and managed access to the markets. And similar for the reimbursement, so the payment of personal medicine, I'd like to highlight that most of the literature points to a value-based reimbursement, progressive risk-sharing agreements, and of course, an early pre-approval again. So that seems to be really what the literature and grey literature points to as a solution for financing and payments. And this is the results based on a survey, what the payers and manufacturers themselves really perceive for success factors that's in line with our findings is also, besides the risk sharing and everything, it's also the simple and measurable outcomes. And you see that both this criterion has scored highest in both payers and manufacturers, which brings us to the next point is we as health economists, how do we make this point? How do we provide manufacturers and payments with measurable outcomes to have them, to use them in managed entry agreements? We know about the issues surrounding the economic evaluation of personal medicine. My colleagues in Oxford, James and Sarah, have done lots of work on this in the last decades. And what I would like to summarize is first, the major points, the major challenges for health economists. I cannot really stress enough for those that are not health economists and they're not involved in personal medicine, the magnitude of the challenges in this specific area. We're talking about the analytic approach, the measurement of costs, which in other interventions is really straightforward. Here, there is, as I've shown before, lots of fluctuation in the costs, even per of the intervention, per genome sequencing, etc., etc. Measuring of effectiveness, of course, we don't have, most of the times, we don't have large RCTs as we should be having. And many times, this is the most challenging responsibility is measuring outcomes. So there are arguments that they suggest that cost utility analysis is not enough. And we've seen that these arguments published in the literature that we should be going beyond the cost effectiveness analysis. We should be looking into other elements of value that are not captured in a quality adjusted life year. And probably we need to have these exceptionalism for personalized medicine. But let's see what this value is in all these arguments. This is the value flower, I suppose that's well known to you, published in Value in Health. In the green bubbles, this is what we traditionally include in the cost utility analysis, QALYs and net costs. Sometimes when we take the societal perspective, we look into the productivity, the impact of the innovation to productivity, and of course, the adherence to improving factors. But then the authors here, the ISPOR task force, came up with all these additional elements of value that possibly personalized medicine would have impact upon. And therefore, they do suggest for us health economists to go and value them. However, there was lots of criticism, and I saw here the Mickey Mouse model of Andrew Briggs that was presented at ISPOR last year. And what he argued is that for many reasons, you just start taking off the additional elements of value. He end up with probably the conventional analysis with QALYs and net costs, and then having just equity and the severity of the condition really as the only elements to be considered in the decision making. And I suppose the criticism of these additional elements of value is about it's really unclear how to measure these and monetize, obviously, these additional elements. There is a risk of double counting between the different elements of value. The task force, I suppose, has focused only on the positive value elements and left out the negative ones, but also how we can pay for these additional elements. There is an explicit trade-off between additional elements of value and QALYs, and of course, even if we do have the impact of personalized medicine on all these additional elements of value, should payers really pay for these additional values, or do we have to ask taxpayers really to reward for these additional elements of value or not? So this is an example that's very simple example that the decision could really change of, let's say, this treatment A over B if we included the value of hope, let's say, in a very simplistic scenario. And of course, that highlights the impact that the decision could have if we were to include additional elements of value. Now, value-based pricing has been, I suppose, on the stage and the forcing of these of personal medicine for many years. And what it is really we have the reference price of the existing innovation, we have the positive differential value of the personal medicine, we take out the negative differential value, and we end up with really the value of the innovation. And the value, of course, the differential value could reflect savings in healthcare, quality of life, productivity gains, value in use, etc., etc. Now, we have, as health economists, we do have frameworks to support or to measure value of personalized medicine. This could include the net benefit approach, or multi-criteria decision analysis, or weighted QALYs. I don't want to get into the details of it, but I just want to highlight that there are all these frameworks developed, indeed, to try to go beyond the quality adjusted life year. I'll just want to point how we could use this framework, two of these frameworks, in this case. So having the net benefit here would need to have a willingness to pay for all these additional elements of value. So we need to assign monetary values to each one of them. And then we need to subtract the costs of the intervention from this monetary value to get the net benefit, which I suppose you can agree with me, which is very challenging really to get a monetary value for all these additional elements. Now, another way would to have a multi-criteria decision analysis, so to have all this, so to have personal medicine versus comparator, then we can measure the performance of the two on the different additional element values, and then we can assign relative preferences on these performances, on these criteria, based on the preference of stakeholders. So let's say severity of the disease could have a higher importance than costs, or etc., etc. And then what we could end up is the overall value score. And then using something that my team developed in Oxford is the conditional multi-attribute acceptability curve, which is similar to the CAC, the cost-effective acceptability curves, to get the probability of the treatment of personalized medicine to be cost-effective or to be acceptable at different levels of budget. So that gets also the budget impact elements into account. Another thing I want to discuss is the value of information. Obviously, innovations and early market entry agreements, they're not based on solid evidence. Maybe the value of information could point us to what is the area, what are the input parameters we should be focusing upon when we conduct further research to reduce uncertainty. And of course, that could improve the outcomes and assess the value of the research itself. But this is only applicable when we have available estimates of performance costs, of treatment costs, improvements to patients' quality of life, and patient population size. And many times we don't even have these estimates. And of course, a value for information analysis would be problematic if the cost utility was not good enough to be taken into account. And as I've shown so far, there are these arguments that we should be going beyond the QALY. Now, going back to the HEcoPerMed, what we've done to reduce uncertainty between the economic evaluations, the consistency, to improve the consistency across the economic evaluations of personalized medicine, we did another literature review, expert interviews, systematic literature review, and also a workshop with experts, health economists, modelers, and assessors of health economic models. And we came up with a list of 21 recommendations about the perspective and discounting to be followed, the test and treatment combinations, how this should be modeled, how the effectiveness should be then, how, for example, the modeling of surrogate outcomes in the short term should also be incorporated, as well as the hard endpoints of mortality and quality of life of patients' lifetime. Of course, compliance should be in the models, and we give guidance on this and how we deal with uncertainty. But what I would like to point is the last two issues really of the guidance, which is about how we go about the additional elements value and the incorporation of managed entry agreements in the economic evaluations. Now, in HEcoPerMed, we have 3 case studies. The first is about genetic testing of MODY, monogenetic diabetes, led by the Syrian team. We also have tumor agnostic treatments with NTRK fusions, led by the Dutch team. And we also have ToxNav, a genetic test that we in Oxford evaluate that shows the level of risk of patients, cancer patients, to have adverse reactions on first-line chemotherapy. And we have done this selection based on predefined criteria, just to have a nice variation of, or to capture variation of personalized medicine across the continuum, just to demonstrate good practice of modeling based on the guidelines we have developed, and of course, to show exactly how this could be done. In the NTRK, the economic model of the NTRK fusion, as I said, that is led by the Dutch team, we have included the managed entry agreement, which is in place. So the manufacturer is already in an agreement with payers. And what we've done in our economic model is we include different elements of this agreement. For example, the costs of the drug is limited to certain amounts. This is based on capping on monthly treatment costs, capping on annual treatment costs, etc., etc. And we also have in our model, we have also modeled the outcome of this drug in a way that the drug is only applicable to those patients that exceed a certain number of progression-free weeks. And this is how we come up with really the integration of market entry agreements, so a payments model with our own economic modeling. And this is another example based on the Toxnav that we include an additional element of value on top, of course, on cost, quality of life, and life years or QALYs in the evaluation of Toxnav here in Oxford, led by us, is where we include also the value of knowing. So we try to capture whether patients that know whether they have predisposition on having adverse events because of the chemotherapy they're about to receive or not, that would have any impact on the ICE really of Toxnav. Now, that brings me back, and I'm going to be very fast with the ideas on how we can get it right. I really got the first message, I suppose, is that, okay, I think we all agree that risk stratification is not enough, and we need to do something more than that, something that highlights and captures really the effectiveness of personal medicine, and of course at reasonable costs. We need to have an aligned evaluation, development phase and evaluation of diagnostics and drug development. We need to identify what are the conditions that would make a personal medicine innovation optimum for the society and, of course, and the payers. Real-world data gets back to the center of the discussion, as Vibeke mentioned in the beginning, and that would be crucial if we're to engage into outcome-based risk-sharing agreements. And of course, we need to invest more on infrastructure and administration of such agreements. Of course, health economists could have a central role into that, but we need indeed lots of data. We need all parties to be heavily involved into this. So probably where we are at the moment is we have these approval points where regulators are on the left side and payers on the right side, or as you can see it. And then we have different evidences that the assessors are focusing upon. And of course, then we as researchers, we follow what type of study we have to conduct in order to inform these evidence. But what we really need to is we need to have an engagement of payers and regulators in a mutual engagement just before for the payers and after for regulators. We need to look into the relative efficacy and safety and effectiveness of the interventions from the very beginning. So we need to have more adaptive models here, adaptive RCTs. We need to use more observational studies, more meta-analysis, so data synthesis and evidence synthesis. So we need to use all the power we have as research community, but also as data, the data availability we have at the moment, in order to maximize what we can capture. And of course, we can revise things along the way, rather than waiting until we have the perfect evidence really to be really risk averse in our decisions to be taken. And the last slide that I've promised to show you I'm terribly sorry, I think my laptop just crashed. And it's really the last slide. So do you mind if I restart the program, or?
Sorry.
Do you have time, Eline? Probably
yeah.
not.
Yeah. So would you like to stop, if you stop sharing and open it again, would you like to do that? Yes, please. Yeah.
This is again another, We're talking about big data and then the laptop crashes, right? This is right. I'm not sharing anymore.
No, you're not.
Would you like me to share the last slide, or shall we move on to the Q&A considering the time?
Yeah, I think we'll stop. I think it's better. So see if yeah, it's let's stop here and we can. So there is a question here. So I was wondering about. Thank you so much. First of all, thank you so much for an excellent talk and highlighting a lot of these new challenging. And I think it was nice that you used a lot of time on the financing and that there's a need for a more integration between different. Between the public, between different stakeholders. I do have a question for you. So in one of your slides where you have this, there's a question with the different elements that need to be valued, and one of them is a reduction in uncertainty. And I have a question. There's a question about that. Is in precision medicine, is it certain that we're going to reduce uncertainty? What do you think?
I suppose if we conduct more research, it is more certain that we're going to reduce the uncertainty, whatever the outcome is. So even if it's not really effective or not cost effective, this is also very valuable in around the uncertainty of the ISA. So of course, what I'm arguing is that we need to be clever and smart on how we design the collection of further data, and therefore I think that yes, the uncertainty would always be smaller by conducting more analysis in the future.
Okay, yeah, because I was so my comments were more related to what happens when you when the samples are really small, you know. So actually, when you're towards this n equals to 1. When you really have this targeted, then how are you going to look at uncertainty in then? Absolutely.
So obviously at that point we can't do much. We have seen basket trials, or we see that we pull more patients in time to increase the sample sizes, but of course it's going to need more data as we go in time, as we have already provided the intervention to patients, and then we try to get some more information later on. It won't be ideal again. I'm not saying that's going to be uncertainty is going to go to 0%, but at least we're going to be a bit more certain about certain things.
Okay. So here's a question. So there's a question here. So has your research focused on other omics, such as proteomics and metabolomics, and how they may factor into reducing uncertainty? So is this something you're familiar with?
So obviously we haven't captured everything that could be labeled as personal medicine, but I suppose metabolomics and other innovations would be evaluated in the same manner that we have developed. I mean, the health economics framework would be the same. I don't see any reason, unless the person has asked this question, thinks that there is something peculiar with these innovations that would not really allow our own framework to be implemented in the evaluation.
Okay, so thank you, Apostolos. I think we need to close this session now and go further to the next part of the program. Thank you so much for your talk, and I think you will join us a bit longer. So thank you so much. So the next part of this seminar is some pitching some research. And the first who's going to present his research is Lars Asphaug. He's currently at Oslo Economics, He's a former PhD student at the Department of Health at HELED, our department. So please, Lars.
Thank you, Lina. I'm going to share the screen. Let's see here. So, can you see this now?
Yes.
Great. Okay. I got to close the little sidebar there. All right. Thank you for having me as a speaker. I am Lars Asphaug. And as Lina said, I'm working at Oslo Economics. I used to be a PhD student at University of Oslo, and I also spent some time at HERC last year. So it's real nice to see you again, Apu, and it's nice to see that there's continued sharing of ideas between Oslo and Oxford. My PhD work consisted of 3 empirical papers on cost effectiveness of personalized test and treat options. But I also had a chapter in my dissertation that was more of a general theoretical model to tie the papers together and say something more general about what determines cost effectiveness of personalized interventions. So I'll give a really condensed version of that now. It's more like an economics lecture on the mechanics of cost effectiveness analysis. And beware, there will be a few equations. So I'm going to go through this little model, and I'm going to show a few equations, like I said, on the left side, and I've tried to break it down to a human level on the right side using graphics, but we'll see how well I manage that. So in this first model, we have a group of people who are all initially healthy, but at risk of getting sick. And the risk of disease is P. And we can first assume that everyone has the same risk. And we can also assume that you will be happier staying healthy than sick, and that your utility is higher when you're healthy. So we can think of the relevant costs here as the value of medical resources attached to the treatment of the sick. And what we really want to focus is on the changes to the group over time. So that's what these deltas mean, the delta U and the delta C, that's a change in time. So like I said, initially everyone is healthy and happy. But if you follow the expected values for them, some of them will of course get ill and experience a lower utility, while others remain healthy. So the changes in utility, the changes for the people who stay healthy, the utility doesn't change, but the proportion that get sick, they have a loss of utility. And they also incur some costs, and that's the same proportion that gets that. So very basic insight number one is that in a group of at-risk people, for example, defined by a common diagnosis, some will become sick and lose utility and incur some costs. Of course, most diseases have treatments. So we can assume that there's a treatment that can reduce the risk of disease by some factor. So here the post-treatment risk, pi, is the pre-treatment risk, lowered by some proportion, the delta there. And this treatment has a certain degree of discomfort and a certain cost. And treating all in this group has 2 main utility effects. So because treatment reduces the risk of disease, a smaller proportion gets sick and lose utility from disease. However, as treatment has a disutility attached to it, the whole group will lose some utility from getting treated. And the same happens cost-wise. A smaller proportion will get sick and require medical attention, so this reduces overall cost, but since the whole group is treated, cost also increase some. So very basic insight number 2 is that treating all reduces utility loss for those who would otherwise get sick, but adds treatment cost and reduces everyone's utility a little bit. Okay, so patient groups very often display some degree of between-patient differences. And some of these differences are very relevant to treatment outcomes. For example, disease risk and response rates, And if we now assume that the patient group consists of two types of people, the A types and B types, we can assume that only the A types are actually at risk and the B types are not, which is a very strong assumption, but that's just for illustration. So if you now look at the changes in expected outcomes, it's clear that only A types have any change in utility and medical costs. And if they were treated, only the A types would benefit from the treatment, and the B types would objectively lose utility from treatment. So insight number 4 is that treating when the true type is unobservable can improve the situation for those actually at risk, but not for those not at risk, and they will only experience utility loss and increased costs. Okay, so finally we get to the personalization. If we had some kind of marker that we could use to measure each person, we could classify them according to their results being above or below some normal limits. And I'm sure you've seen this table somewhere. So if you test above the limit and you are in fact a type A, like the actually at-risk people, you would be a true positive. But if you're actually a type B, you're a false positive, and vice versa. So the sensitivity, the alphas, and the specificity, the betas here, are very important because they decide how well we can optimize treatment if we decide to treat according to the test result. So we would like to treat the people in the inner left column, but we actually end up treating the people in the red row here. And of course, we can also fail to identify and treat some as well, which would be the false negative. So which of these errors have worse downstream consequences really depends on other variables. But in this simple model, we could have the utility loss and cost from disease for false negatives being that downstream error, and for the false positives, you would have the unnecessary treatment costs and the unnecessary loss of utility from treatment. Now, this only applies if you have an imperfect marker to stratify risk. If you have a perfect test, you would not have these long-term issues. So, by testing and treating only positives, we will reduce the utility loss for some of the A types, but we also fail to treat some of the A types if the test isn't perfect. But compared to treating all, the testing first reduces the false positive error, unless the test is, of course, fully useless at finding B types. And that tells us that if the marker is reasonably good at separating the true types, we can increase the precision of choosing treatment options. So all else equal, adding the stratification step, overall costs will increase vis-a-vis group treatment, treat-all approach, unless the reduced costs from unnecessary treatment offsets some of the cost of testing, which I believe is what I said in that box. So yeah, the algebra is a lot more messy when you add in these test results and try to look at the dynamics there, but there are very many interesting angles to looking at it from this way, I think. And unfortunately, I'm out of time now, I believe. The plan is to develop this chapter into a paper. So if you're interested, look for an article in the coming decade or so. So yeah, thank you.
Thank you, Lars. So I think the way you are dealing with the different trade-offs between target things and disutilities and cost of testing shows the complexity of working with this area of precision medicine, which is important to be aware of, and yeah, to develop tests in so they are appropriate in have a high quality, are sufficiently accurate. So I think we'll just have to move on. I think if we can, I will, there's not been a lot of Q&As currently, but if you have some questions as we go along for the other projects, just write them in, and then I'll provide some of these questions for everybody, also Lars and all the others later on. So now, Lina, the next presenter is Lina Gruneau. She's from Linköping University, and she's a PhD student there and a collaborator on the PRECISE project. So please, Lina.
Yeah, thank you so much, Eline, and thank you so much for inviting me to speak today. So yes, my name is Lina Gruneau. I'm a PhD student at Linköping University. And I will today talk a little bit about precision and uncertainty in the evaluation of diagnostic algorithms in non-alcoholic fatty liver disease. So this is the outline of today and, well, the future. I will shortly mention the PRECISE project and non-alcoholic fatty liver disease, and a study which we have just currently started working on, which will assess the cost effectiveness of management pathways of non-alcoholic fatty liver disease. This will in the future be extended in order to understand the overall uncertainty, heterogeneity, and value of information when evaluating complex test and treat management strategies. But we thought that non-alcoholic fatty liver disease is a good place to start for future analysis. So this study is part of the PRECISE project, which is funded by Nordforsk. And the PRECISE primary objective is that it will contribute to better healthcare decisions that facilitate the implementation of cost-effective intervention for personalized medicine by developing novel methods within health economics, generating new evidence, and improving current national pharmacoeconomic guidelines. It consists of 2 work packages, and this study is in the framework of work package 2, which focuses on the right treatment to the right patient with the right evaluation methods and research portfolio. So non-alcoholic fatty liver disease, or NAFLD, it is the buildup of fat in the liver in the absence of alcohol abuse, and it is the most common liver disease in the Western world. It has a prevalence of 25%, and it correlates with diabetes type 2, obesity, and metabolic syndrome. Most NAFLD patients don't have any symptoms or even progress in the disease, but some develop inflammation, which is then called non-alcoholic steatohepatitis, or NASH. Some patients even develop cirrhosis or even in the end stage liver cancer. When diagnosing NAFLD, a combination of tests is usually used, and liver biopsy is still the gold standard and often used as confirmation. But due to its invasive nature and costly nature, other alternatives are emerging. There's also a question of how to combine these different tests and where to test these NAFLD patients. As a part of work package 2, we started by conducting a systematic literature review in order to analyze how previous studies had modeled the natural history of NAFLD in economic evaluation studies. We found that there were quite large differences in the model structure between the studies. For one, how they modeled the NASH and NAFLD, and also with which complexity and granularity they modeled fibrosis journey. So if they clumped them together or if they modeled each fibrosis stage separately. There are also differences in how the advanced stages of the disease was modeled. But based on what we found in the literature review and based on the theory of NAFLD and discussion with our liver clinicians, we will model the natural disease progression as this. One important aspect which we incorporated in our model was that we, in line with another study, created hybrid health states for liver cancer, or HCC, so that patient had a combination of liver cancer with compensated cirrhosis and decompensated cirrhosis. And this model will be used to answer the objective of the study, which is to evaluate different management pathways used to diagnose and follow NAFLD patients. So these are the different management pathways. So we have a combination of three different combinations of tests in primary care and 4 different combination of tests in specialist care. And the standard of care is the Swedish management pathway. And when there's a suspicion of NAFLD in primary care, the patient undergo fibrosis 4 and NAFLD fibrosis score diagnostic testing. The patient is then classified as either having a low risk or an intermediate high risk of advanced fibrosis. If they are low risk, they stay in primary care, but if they are deemed as intermediate or high risk, they are referred to specialist care. And in specialist care, they then receive a combination of fibroscan, MRE, and liver biopsy. And based on these test results, they are classified as either low risk or intermediate high risk of advanced fibrosis. If they are classified as low risk, they go back to primary care, but they repeat this diagnostic algorithm again in like 3 years. And if they're deemed to be in intermediate to high risk of advanced fibrosis, they stay in specialist care, and then they are screened for liver cancer and decompensation liver, among other things. However, there are a number of challenges regarding evaluating such a management pathway. And currently, as we have just started, we may have more questions than we have answers. But I'm going to lift a few of these challenges, which we perceive we will face, but we hope through this project, we will be able to further explore. Regarding diagnostic information, a complex diagnostic algorithm creates uncertainty in the pathway as they are complex and can be combined in different ways. Furthermore, can the test performance vary in patient subgroups? For instance, in this case, it is more likely that the results of the FibroScan test results are inconclusive if performed on an overweight person. There is also difficulties in defining the clinical practices, as for instance, due to FibroScan often yield an inconclusive result, the test is performed several times in reality. And in regards of the management decision, the management pathway can depend on other factors than diagnostic tests. For instance, can a patient be involved in a shared decision process where preference of the patient or even the doctor is influencing the pathway? And this is, of course, difficult to define such behavior or characteristics and model them. And all these lead to differences in implemented treatments, and these treatment implementations can vary further with patient heterogeneity. This leads to differences in patient outcomes and healthcare costs, which are further uncertain due to previous parameters and smaller patient populations. So I talked some of the challenges relating to evaluating complex management pathways, and they can be summarized to these. We have genuine uncertainty, which we cannot handle in a similar way as statistical uncertainty, where a bigger sample of the patient population can be obtained in order to lower the uncertainty. We refer to genuine uncertainty as uncertainty connected to complex diagnostic sequences, difficulties in defining clinical practice, and other factors than tests which can influence the management pathway. Statistical uncertainty is due to smaller subgroups, extrapolation of effect, and the heterogeneity in the patient population. However, this project links to overall objective of PRECISE, and the question of further development of the model is rather how the overall heterogeneity and uncertainty in the management pathway affect the decision basis and the value of obtaining further information and which information which is most optimal to obtain. So these questions will be able to be explored in the future, and they will build on the model and the result that this study is hopefully going to yield. So thank you for your attention.
Thank you, Lina. Thank you for your overview of this complex area of diagnostic testing in this disease group. So I think we'll just go on to the next one, but please, there's a very quiet audience today. So please, if you have some general question, please bring them forward and I will raise them to each of the speakers later on. Okay, thank you so much, Lina. And then Mathyn. The next speaker is Mathyn Vervaart. He is a PhD student at the University of Oslo, but is also at NOMA. And it's also part of the PRECISE project. So please, Mathyn.
Thank you for the introduction, Eline. I'll just try to share my screen. All right. Yeah, so I'd like to present our work on model average expected value of sample information for from ongoing trials. So this is a method that can be used to quantify the consequences of immature trial evidence for informing coverage decisions. This is joint work, and I would therefore like to thank my supervisors Eline, Mark Strong and Carl Claxton, and my collaborators Nikki Welton and Torbjörn Wieslev. So the project is also part of PRECISE, which is funded by Noorforsk. The views expressed in this presentation are my own. So I'd like to start with the background to the project. The European Medicine Agency has in recent years allowed licensing of new pharmaceuticals more quickly at an earlier stage in the clinical trial process. And when evidence is obtained from a trial at an early stage, the events of interest, such as progression or death, may have only been observed in a small proportion of patients. And this is typically referred to as immature survival data. Now, an example of immature survival data is shown here, taken from a technology appraisal at NICE in the UK for a drug called daratumumab in combination with bortezomib and dexamethasone for treating multiple myeloma. So after a median follow-up time of 27 months, most of the patients in the trial were still alive and had not experienced the event of interest. And follow-up was to continue for an additional 4 years. So the manufacturer had extrapolated survival over a time horizon that was over 10 times greater than the observed follow-up duration from the ongoing trial. And different survival models gave very different predictions of long-term survival, generating large uncertainties surrounding estimates of cost effectiveness. The immaturity of the survival data therefore translated into a greater risk of making a wrong coverage decision that could negatively affect the healthcare system and population health. Now, the expected value of reducing uncertainty through collecting additional evidence can be quantified by computing the expected value of sample information, the EVSI. Additional evidence can be valuable as it can lead to better decisions that improve health and reduce resource use. Now, EVSI has typically been described in the context of designing a future trial, but little research has been done on EVSI for trials that are ongoing at the point of decision-making. And when a trial is still ongoing at the point of decision-making, there may be value in delaying a reimbursement decision until additional evidence has been obtained from the ongoing trial and uncertainty has reduced. So the aim of our study is to extend EVSI methods to situations where trials that investigate the time to event endpoint are ongoing at the point of the adoption decision-making process. And this is a typical situation for many newly marketed oncology drugs. So we address two types of uncertainty caused by immature survival data. Parameter uncertainty relates to the imprecision with which parameters used to extrapolate survival are estimated based on limited immature data. And structural uncertainty in this context relates to the uncertainty in choosing between alternative survival models that may result in different survival extrapolations. So onto the methods. I'd first like to introduce some general notation. So we assume that we are faced with a decision problem with decision options denoted by D. The net benefit of decision option D is denoted by NBD. We have a model that predicts the net benefit of decision option D given a vector of input parameters theta. Our current judgments about the model parameters theta is represented by the joint probability distribution of theta. Now, a future new study would provide as yet uncollected data X that is informative for some of the model parameters, giving a posterior distribution of theta given the data. EVSI is calculated as the difference between the expected value of a decision made after collecting the data X, which is the first term in equation 1, and the expected value of a decision based on current information, which is the second term. Now, the traditional gold standard approach to computing EVSI is based on a two-level Monte Carlo procedure, in which plausible new data sets are generated in an outer loop and used to conditionally update the parameters of the decision model via Bayes rule. The updated parameters are then sampled in an inner loop to estimate the posterior expected net benefit, conditional on the generated data sets. Now, the use of Markov chain Monte Carlo methods is required when the prior parameter distribution and the data likelihood are non-conjugate. So for an ongoing trial, we want to estimate the value of potential future survival data, X tilde, conditional on having observed data X during current follow-up time T0. We want to characterize the future survival data as a new piece of information that updates the joint prior distribution of the model parameters. However, we need to avoid double counting the observed data X when computing the likelihood for the future follow-up data. So we therefore need to use a truncated distribution when we compute the likelihood. And the general likelihood for a given survival model with hazard function h of t and survival function s of t is given by equation 2. In order to account for left truncation, we divide the original likelihood in equation 2 by a survival factor given the left truncation time tau L, which corresponds to the current follow-up time. And unlike censoring, truncation doesn't add any data points to the likelihood, and we thereby avoid double counting the observed data when computing the likelihood. So I'd like to go through a hypothetical simulation example for the Weibull distribution. In this hypothetical example, an ongoing trial investigates survival for a new treatment and standard care. And we simulated two data sets that represent an increasing and decreasing hazard. And in this example, we will only consider survival and not any other model parameters, such as cost or quality of life. Now we want to learn the value of extending the trial follow-up time of 12 months to determine whether more mature evidence is needed before making a decision. And this means we need to perform an EVSI analysis for conditional survival times, since we have already observed 12 months of follow-up data. The expected incremental survival benefit is about 7 months for both data sets, given a time horizon of 20 years. Now we use the statistical package STAN to perform the Bayesian updating procedure. STAN implements Markov chain Monte Carlo using Hamiltonian dynamics, which means that the gradients of the distribution functions are computed in order to improve sampling efficiency. And the output produced by STAN is the posterior distribution of the Weibull shape and scale parameters given the generated data sets, which we use to compute the EVSI. Mark Strong and colleagues have developed a fast non-parametric regression-based method that greatly reduces the computational burden of the two-level Monte Carlo procedure to EVSI. And their method only requires the results of a probabilistic sensitivity analysis and generating potential data sets given the prior distribution of the model parameters. Now, a generalized additive model, GAM, is then used to regress the prior net benefits on the summary statistic of the generated data, thereby avoiding the need for using MCMC methods. Now, the table on this slide gives the MCMC and GAM-based EVSI estimates in terms of life months for the two hypothetical data sets. The first column gives the new future follow-up times, and the other 4 columns represent the EVSI estimates and the standard errors. And for both the increasing and decreasing hazard data sets, the EVSI reflects diminishing marginal returns for increasing follow-up durations and converges towards the expected value of perfect information, the EVPI, which represents an upper limit to EVSI. Now, the EVSI varies depending on the underlying hazard pattern, even though point estimates of mean incremental survival benefit are similar for the two datasets. The GAM method agrees well with the MCMC method, but at a greatly reduced computational cost. Now, in case we are uncertain about the choice of survival model to extrapolate the observed data, then we would like to reflect this in a model average EVSI analysis. So we now have a vector of alternative models denoted by M. And the prior model probabilities are those that are conditioned on the data X that to be observed during the current follow-up time. Additional follow-up time would provide data X tilde that is informative not only for the parameters theta, but also for the choice of survival model M. And the expression for the model averaged EVSI, using the same sampled values for theta in both terms to reduce the Monte Carlo error, is given by equation 4. Now, the table on this slide gives the MCMC and GAM-based model average EVSI estimates, again in terms of life months, for the two hypothetical data sets, assuming uncertainty about choosing between Weibull, gamma, log normal, and log logistic survival models. And we derived the prior model weights using Akaiki's information criterion, AIC. All model average EVSI values for additional follow-up are greater than the single model EVSI values. And similar to the EVSI results for a single Weibull model, the model average EVSI converges towards the EVPI, reflecting diminishing marginal returns for increasing follow-up durations. And as before, the GAM method agrees well with the MCMC method, but the computation time is reduced by a factor of nearly 8,000. So I'd like to conclude with a brief discussion. A general limitation to computing EVSI is that generating potential data sets may not be straightforward for complex study designs. Furthermore, deriving prior model weights from likelihood-based measures such as AIC may not always be appropriate when data is immature, since these measures do not have any bearing on the longer-term plausibility of the extrapolations. So to conclude, EVSI for additional follow-up data could be used in day-to-day decision-making to quantify whether the benefits of approving a promising but uncertain technology outweigh the cost of valuable evidence forgone. And this provides incentives for manufacturers to either reduce the price and gain early market access, or to submit additional evidence and be rewarded with a higher price. And managed entry agreements could also potentially play a role here. Now, decisions that fail to account for the value of evidence forgone may lead to the introduction of new technologies without sufficient evidence. And this may undermine the evidence base for future clinical practice and reduce population and health benefits. Thank you for listening.
Thank you, Mathyn, very much for so here's a question. So there's a question to you, Mathyn. So there is thank you for an excellent presentation. And what is the relevant application of EVSI in a rare condition or small stratified population?
Well, I suppose EVSI can point us in the right direction in terms of what type of evidence is needed to reduce uncertainty. So one issue with rare diseases could be that if a cost effectiveness model isn't basically isn't giving the right answers, then EVSI will also not give the right answers. So that is an important consideration. You need some kind of data to compute EVSI as well, just like you would need some data to compute an ICER. But I guess the most important takeaway would be that it could help to point us in the right direction of what type of evidence we would need.
Thank you, Mathyn. Thank you so much. Okay, so then it's to the next speaker, which is Monica Gomez, who is a research assistant at our department. And she's been on a BigMed project and evaluating genetic sequencing and going to show a cost utility analysis. So please, Monica.
Yeah. Good afternoon, everyone. So I'm gonna try to, this is a more concrete example of what we are trying to do in health economics. So it's a cost utility analysis for the MedAction study. It's in the field of precision cancer medicine. So first of all, precision cancer medicine emerged from the evidence that showed that tumors' response to medical treatment was driven by molecular vulnerabilities or molecular markers. So the challenge has been to identify these molecular markers, but also those resistance markers that could interfere with the tumor's response to treatment. And all of these, of course, while maintaining patient safety. So the aim of precision cancer medicine is offer each patient a treatment that is tailored to the tumor's molecular characteristics to deliver a more effective and safe treatment. So the MedAction study was developed in university hospitals in Norway. In total, 26 patients were eligible. These patients had end-stage cancer from various types, and they were screened for actionable targets or molecular vulnerabilities. The most frequent tumor entity was colorectal cancer. So this is important for the choice of comparator that we made, and I will touch upon later. And in total, 13 patients were tested positive for an actionable target. But 10 patients out of these 13 started molecularly matched therapy. 3 patients from these 13 did not receive therapy due to poor health conditions or the presence of resistance markers. So they were classified as not having this AT. So in total, 16 patients then received therapy, and this included 13 patients who tested negative for an actionable target, and these 3 patients that I mentioned. So the whole process started with a biopsy of the tumor, and then through a molecular analysis, these actionable targets were identified to be able to match a therapy. So in the model, the population were patients aged 60 years old with different types of end-stage cancer. The intervention was then the molecularly matched therapy through the identification of these actionable targets. And the intervention was then divided into the MedAction study as a whole, so the 26 patients, and the positive subgroup, so those patients with an AT who were treated with matched therapy. We chose 3 comparators. So the negative subgroup of the MedAction study, so those patients without an AT who received standard therapy, and the correct and TAS studies that I will touch upon later. The next slide. The time horizon was set at 10 years. The cycle length was 2 weeks, and the perspective was that of healthcare, and life years and qualities were the outcome measures. So regarding the comparators, we chose as I mentioned, the negative subgroup of the MedAction study that received best supportive care, and the placebo arms from the correct and the TAS studies. These were chosen, as I mentioned in the first slide, because these are studies that assess the effect of different treatments, specifically on patients with end-stage colorectal cancer. So we thought this was the closest match. So the data were extrapolated from Kaplan-Meier curves from these studies, and progression-free and overall survival curves were elicited from these. And we can see that when we divide a med-action study into the negative and positive ATs, those patients that have an actionable target actually have longer progression-free survivals. And when we compare the med-action study, the whole 26 patients, with the correct and TASE studies, we see also that progression-free survival, it's longer for the med-action study. And something similar can be observed for overall survival. Patients with a positive actionable target live longer, and the med-action patients also live slightly longer than those in correct and TASE studies. So from this, we made a model with 3 health states, where progression-free survival and the dead health state were calculated from these estimates, extrapolated estimates, and the progress health state was defined as those patients that were not in progression-free nor in the dead health state. So when we see the total cost per patient, according to treatment group, we see that indeed the med-action and the med-action study and the positive subgroup of the med-action study are the interventions that have the highest cost. And we can also observe that this is mainly driven by the sequencing and the matched therapy. But we can also see that when we compare med-action with correct and the TASE studies, we see a cost saving regarding best supportive care and adverse events management. The qualities were retrieved from studies that assessed the health effects on patients with end-stage colorectal cancer. And when we look then at the incrementals and the ICERs, that we'll see that the med-action study as a whole and the positive subgroup of the med-action, those are the most costly interventions. And we see that this difference is even larger for when we only compare positives and negatives. We see that the costs are 3 times higher for those positive AT patients, but this is also the comparison that yields the most QALYs and life years. And this can be reflected also in the ICER. So after running the PS probabilistic sensitivity analysis, we can see indeed that the comparison between positive and negatives there is a 50-50 chance for each intervention to be cost effective before the threshold that in this case was set as 605,000 kroners through the absolute shortfall method. And when we see med-action against TASE and correct, we see that this point is reached slightly after this threshold. And it's the same for the case of life years. So as concluding remarks, and as we've been talking about all these, and Dr. Apostolos also mentioned, of course, there is a lot of uncertainty. And in this case, there is a lot of uncertainty in the choice of comparator. First, because these patients have very specific characteristics. These molecular markers, it's very hard to match something with it. And also, these groups become so small. So at the end, for example, we had only 26 patients here, so that makes it very challenging to compare, to have a comparison group. As we mentioned, the main cost drivers in med-action were mainly the cost related to sequencing and the matched therapy. But we see some cost savings on best supportive care and adverse event management. So the benefit of precision cancer medicine then would lie in decreasing adverse events incidence and increasing quality of life in end-stage cancer, which is so important for patients. And the health benefit it will be likely to increase with an increase in the prevalence of tumors with an actionable target. And that would be all. Thank you.
Thank you so much. Thank you so much, Monica. So I think this study shows. I don't have my video. There it is. So I think this this study shows a starting point where you compare positive versus negatives, and that would provide a more positive answer if you compare precision medicine towards a more general comparator. And then the question is, what should that general comparator be like? Yeah. Thank you, Monica. So very at the end of this session, I will share my screen, and just to give you insight of a project that fits very well with one topic that Apostolos was also addressing. So currently there's a lot of effort in Norway to start on more detailed precision medicine pathways in Norway. And I'm part of a project, Insight, which is part of a bigger project called Impress, which is a huge collaboration between the industry and the healthcare sector. So I guess some of the listeners here today knows about this project. And what is interesting here is that it's actually an example of this shared financing, value-based pricing that was addressed earlier today. So here I'm part of the health economics part, the Insight, but you see there's a whole network of testing the genetic pathway that is going to be set up in Norway. So, and this is not something that is just going on in Norway, it's around the world. And here you can see this DRUP study that also Apostolos was referring to. So what I would just say is that the collaboration is surrounding drugs that are already approved, but it's supposed to be a testing system where there's really small groups, and you need to find a system. It's hard to run, or the discussion is that it's hard to run the RCT, so you need to find a different way of selecting patients and which to reimburse and not to reimburse. So this is the same as Apostolos was showing. And here you just see the pathway of patients being with target agents and how they are followed until the third stage, which is where the industry pays, and then afterwards the government should take over the financing of those with an effect. What I would say is that in Norway, we're planning also to collect the data for those not having a target agent and to use those as a comparator and to work on having develop the control group. So that's a big challenge. So in this project, there is several paths. It's about the regulatory pathway around precision medicine and have 7 work packages containing health economics, the statistical analysis surrounding the control group, ethics, the more everything with law, and then more the decision process. So so I think this is a nice way, or this is exactly a project where you will see this interaction between public-private partnership, but also the need for further development of the methods, how to do the evaluation, how to evaluate the health outcomes, how should we do the reimbursement, the different reimbursement schemes. And then as an overarching topic here, I think it's how to express uncertainty when these numbers become really, really small. So this was just a very quick insight to this, but links back to the presentation that Apostolos had earlier this morning. Okay, so then this session here. We're about to close up this this part of the session. There hasn't been any additional question. I would like to thank, first of all, Apostolos for joining us for this session. It's been great to have you. I'm really glad you for giving the talk to us. And then I would like to thank Lars, Lina, Mathyn, and Monica for your presentations. Hardcore health economics, but important presentations within this area. So thank you all. So now this seminar will go over to Norwegian. So I'm going to just stop there and start with my Norwegian.